Heard you all. Whatever time zone you're in, good for me. It just switched into good afternoon. So welcome to Vibe Tribe. I think this is our fifth one, where we have Nicole Piemonte and Ross Bremner with us, and they will be speaking on permission to grieve, post-traumatic growth in medicine. I believe you all have read what they hope to, what they will be sharing with us, not just hope to, they will be sharing with us, and the objectives of that experience. So I will not review that. I do want to introduce you to them, though. Beyond their bio, Nicole and Ross are graduates of HCI. I believe graduated in the 2020 last May, completed the level 2 program with Suzanne, and maybe someone else on the call, and I just am not, Patty?
Patty was with us, yeah.
Now. So they are humble, smart, dedicated professionals, and they're light bearers in helping us see in the dark with ease. That's what I've learned about them, and as they continue to do with their work. They're creators and they are really brilliant storytellers, and I feel really privileged, and I think you all will too, to have this opportunity to be with them today. Laura, you are another member of that cohort. I did not mean to overlook you. Nicole is the Associate Dean of Faculty Leadership for Creighton University, and she's a coach with having well over 600 hours under her belt in that space. She has her PhD in medical humanities, is an author of 2 books, which I highly recommend you to read: Afflicted, How Vulnerability Can Heal, Medical Education, and Death and Dying. And Ross has his MD and PhD. He's a thoracic surgeon. He is an executive director of Norton Thoracic Institute, and they are one of the leading facilities in lung transplants. Is that correct, Ross?
Yeah.
Ross, what I learned in doing a little bit of research there is you were a pioneer in that space, right? Of bringing that online, and I think making that available to hundreds of people, giving them life in the process. And so you give life to your patients, and I would say through your coaching, you give life as well. And what I see on the videos is you probably give some of the best hugs. Like, I loved seeing how you were hugging your patients and the donors as well. So they live with compassion and open hearts, and I think we're in for a real treat to have them lead us today. So I'll turn it over to Nicole and Ross, and welcome everyone, and thank you for being here.
Thank you, Janet. Thank you for that very generous introduction. Grateful to be here and really grateful for the invitation. So thank you to HCI for inviting us to be part of the Vibe Tribe. As you mentioned, we're going to be talking about really emotion in medicine and in particular grief in medicine, and providing a context and understanding for what people are grieving in medicine that we think is applicable to coaches. Those of you who are coaching clinicians and faculty, that's many of you on the call, helping provide context for that. Anybody in the chat, can you just type if anybody is in healthcare, anybody's taking care of patients, clinicians? Let us know in the chat, just get a better sense of who's here with us in the room today. Jonathan, thank you. Cardiologist, appreciate that. Great. Oh, this is very helpful. Thank you so much. Thank you. Okay, this provides some context. Ross, you're able to see the chat there?
I can, yes.
Okay, wonderful. So we did want to start off by emphasizing some of the competencies, the coaching competencies that we want to emphasize today in the work that we're doing. I just want to highlight a couple of them. Ross and I were talking about the importance of a coach maintaining confidentiality, especially when working with a clinician. There's a lot at stake there if they're going to be talking about how they're genuinely feeling, what they might be grieving, medical errors, and how important that is. You know that there is a stigma around clinicians talking about these things. So that trust and confidentiality are critical for coaches in this space. The idea of competency 5, coaching a whole person. We believe that having a professional and personal self, those are not really separable, that the whole person is always in that coaching space with you. If I can return real quick to competency 1, Ross and I were talking about the importance of recognizing that we are not therapists and we are not grief counselors, and we are not going to pretend to be doing that, but a coach still has a role in attending to grief. And then competency 6, the courage that comes with exploring emotions, recognizing when there might be emotions in that coachee and being willing to explore that and to feel comfortable in that space. I really love this quote from C.S. Lewis. He says, "I've learned now that while those who speak about one's miseries usually hurt, those who keep silent hurt more." I think that me as a faculty person, an educator of medical students, residents, and faculty, and a coach for clinicians specifically, this has been true. There is a silence around pain, grief, and suffering in medicine, and that silence really causes a lot of pain. It's important for us to get clarity on what we mean about grief, and in particular, what we mean about grief in healthcare. I'm going to hand this over to Ross, who will share a bit about what grief means and what it means in medicine specifically.
Thanks so much, Nicole. And just sort of for context, it's just preparing for this talk has uncovered sort of almost, my 28 years of career, and just so much grief that I've stored away from, outcomes that have not always been perfect. And my father, who was a surgeon, used to call bad outcomes, he used to call them cortical scars. And just talking to the fact that sort of we actually end up scarring a part of our brains, with these adverse outcomes. But what grief really is it's a result of loss, and sometimes this loss can be pretty profound. What I've learned, and actually, in full transparency, I lost my father almost a year ago, and at the age of 95. And even though I had him for 61 years, it wasn't enough. He was my absolute hero, and what an incredible man. And in order to sort of process some of that, I actually went and sought out some guidance from a therapist. And it's, some of the things that I've learned from that really should apply to the grief that we have in medicine, understanding that this is not just a one-off thing and you can package it up and move on. It really is a long process. It's a little different for everybody, but it is part of the human experience. Everybody experiences grief at some stage. And actually, it's nice to know that it's actually a natural response, even though it is hard. And as C.S. Lewis calls it, miserable, or your miseries. It does actually take work to go through the process and to develop, as what Nicole and I were talking about, it is sort of a skill to grieve, something that we can learn to process, that ultimately, if done in a healthy way, can really lead to growth. And that's really what we want to sort of talk about, over the rest of this hour. But what can grief in healthcare look like? Nicole and I were talking about some of the stories, and I actually honestly remember, as if it was yesterday, my very first experience when I was on call as a medical student. And this is back in South Africa, in a very busy hospital that served a large non-white population, the height of apartheid. And I remember arriving on call all excited. I was going to, do my part to save the world. And the first patient that came in as an emergency, what we called a red tag, because they would put a red sticker on their forehead saying urgent or dringend, which is Afrikaans for urgent, meaning, this patient needs some urgent attention. Well, this patient didn't need that tab because this was a patient that had actually run in front of a moving train. And this was a particularly ghastly experience for myself. The patient had most of his leg degloved, he was missing his right arm at the shoulder, and most of his face was completely unrecognizable. And we all got together. It was pretty chaotic, as you can imagine, trying to find IV access, and trying, almost in vain, but trying our very best to save this poor gentleman. And after about half an hour, we finally called it, and he was pronounced dead. And this was a pretty raw experience for me as a medical student. I remember going home at the end of the shift and just weeping when I got into bed, not knowing, how to process this sort of thing. And of course, the next day we sort of showed up to work, no one really talking about it much, just carrying on as if, nothing really had happened. Then a couple of years ago, fast forward, 28 years or so, actually it's a little longer than that. It's closer to 40 now that I think of it. But, I was about to see patients in my clinic, and I got a call from an emergency room, and a patient that I had operated on a week previously had been walking with her husband, before coming to see me for their first post-op clinic, and she collapsed and was taken to an emergency room. And they called me saying, what happened? What you do? We're trying to work out what happened to this lady. We're trying to resuscitate her. And unfortunately, she died in that emergency room. I had a very brief conversation with the husband in the midst of all of it. But, all of a sudden, I realized that I had lost a patient that I'd operated on a week previously. And I realized that this, it was profoundly disturbing to me. It really became a cortical scar. And even though we'd spent, I'd been in medicine all these many years, I realized that we hadn't progressed at all in terms of trying to have conversations about these and how to process this grief. And in reality, we experience loss almost on a daily basis in medicine, whether you're in the ER, whether you're a cardiologist or a gastroenterologist. And I've seen some of the folk that are with us today. You are going to have, adverse outcomes despite everybody's good intentions. And what do we do with that? And part of the problem is the culture that we have in medicine, and the culture that we hold ourselves to is one of perfection, and the fact that we can do it alone. I remember all the sort of adages that during my surgical training, things like, you don't need to eat every day, sleep is overrated. The trouble with being on every other night call is you miss half the good cases. The crazy things that sort of are driving us to be these superhuman people. And we hold ourselves to that, and we hold ourselves to a level of perfection, which is really unattainable. And ultimately, we find ourselves in the dust, like some gladiators will find themselves, because it's not sustainable. And I think that when I look to burnout, and I talk about this quite a lot in medicine and in my role as a wellness officer for our hospital, I think that a very core problem with burnout is the fact that we experience such loss in medicine, and we don't have a way to process it. I asked a surgical resident just this last week, I said, if you have a trauma and it's particularly tough and you guys lose the patient, is there a process that you guys go through? Has anybody discussed these with you? And he said, no. You may have an attending saying, are you okay? And that will be the sum total of it. So I think as we talk, you'll see that the coach has a marvelous opportunity to allow healthcare workers to unpackage some of this in a very safe environment. So the problem really is that these tragedies occur all the time, and that grief really is almost always ignored.
Thank you, Ross. I don't know, I must say, like Ross, I've heard both of those stories when we were talking about this, and hearing it again, I don't know, it kind of brings up emotions in me. I just want to acknowledge that, and thank you for sharing what I imagine is really hard to talk about, especially because it's never talked about. It's been my experience in teaching and coaching clinicians that in medicine, and then I would say, the space I've been in a lot is medical education. So by extension, the way we train clinicians, disengaged care has been normalized. The not talking about emotions has been normalized. And this is something that researchers have been talking about for a long time. Back in 96, we have this quote that many of the practices and assumptions of medicine seek to escape the reality of suffering, usually through denying it, objectifying it, or sentimentalizing it. The denying and objectifying I've seen a lot. It's really easy to scientize suffering or to just talk about the biological reality of suffering or death and dying while ignoring the existential reality of it. And I was thinking of this quote and wondering about the ways that we sentimentalize suffering. And one example I could think of was very recently, my medical students had their donor memorial to acknowledge the gift that was given to them of their donor bodies in the anatomy lab. And in a lot of ways, the pomp and circumstance around a donor memorial is very sentimentalized of that gift, without students really being able to talk about what they felt like walking into the cadaver lab the first time, how uncomfortable that was for them. Instead, we read poetry and listen to music. And while I think donor memorials are critically important, I think it's one example of the ways that we can sentimentalize death and dying, in particular in medicine and medical education. So I think what's important here is to talk about compassion and what this means. If disengaged care is normalized, what does this mean for compassion? This is Martha Nussbaum. I love this picture of her from the New Yorker. So she's a very famous Aristotelian philosopher. And I say famous kind of tongue in cheek, like as famous as you can get as a nerd philosopher, that's her. But she is an incredible philosopher and writes so much about compassion and what compassion really means. And I have found her work very helpful when I think about medicine and medical education. She says that compassion requires a sense of my own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person, this patient, could be me at any moment. So to have compassion, I have to recognize that I too am vulnerable to suffering. She says, this I will be unlikely to do if I'm convinced that I'm above the ordinary lot and no ill can befall me. I see this with medical students a lot, thinking that I'm the professional, I'm here to help. The patient who suffers is over here. We are two totally separate species. And it is difficult, according to Martha Nussbaum, to have compassion for someone that you see as totally separable and that they suffer and you do not. Right? Compassion, if we look at the etymological root, comes from the Latin, and we have passion, so the suffering of pain. This is why we hear things like the Passion of the Christ, or it's the idea of enduring pain. And com is in combination or union together. So compassion is not pity or feeling sorry for or having sympathy for or even empathy for. Compassion literally means the suffering of pain together, that I can imagine what your pain might be like and I can enter into that space. This becomes really difficult to do when we don't even acknowledge suffering in medicine beyond the biological reality of it. It's important, I think, to talk then about compassion fatigue. We hear this all of the time in medicine, that I need to kind of maintain this distance. Otherwise, I'll feel too much and I will have compassion fatigue. We use this to talk about burnout and we conflate these terms all of the time. So I think it's important to take a closer look at what we mean by compassion fatigue. According to the literature, compassion fatigue is the reduced capacity for compassion as a consequence of being exhausted from absorbing the suffering of others. On its face, this sounds right or intuitive, this idea of being burnt out by the suffering of others. And here is the difference, though, between burnout and compassion fatigue, at least according to the literature. They say that burnout can affect any professional. I suppose you could be a hedge fund manager and get burnt out because you're working too many hours or something. Okay. But compassion fatigue is reserved for those in the helping professions, the people who witness the suffering of others. I suppose compassion fatigue, I think even of a teacher, elementary school teacher who has children who have terrible home life and they feel like they can't help that student. That is kind of the space for compassion fatigue. And then the most obvious example being healthcare, that it's more than burnout, it's compassion fatigue. The problem, I think, with this term, however, is that the perception is that compassion is the problem. Right? When we say compassion fatigue, it frames compassion as problematic. And we see this in the nursing literature. I found this in an article about compassion fatigue among nurses. And they said it makes no sense to nurses to participate in programs to foster compassion because they believe being too compassionate is the root cause of their fatigue. Why would I go learn to have more compassion when that's precisely what's causing me fatigue? And this is what happens when we frame compassion as problematic. The reality is that people are fatigued. Okay, so what's going on here? If it's not compassion that's fatiguing them, what's going on? Okay, neuroscience studies do show that compassion does not cause fatigue. It doesn't. Compassion or co-feeling, like we talked about, can inspire action. And this compassionate action does lead to a sense of satisfaction and connection. We see this over and over again in the literature. When you have compassion, you respond to it, you actually feel good and feel better. Okay. And compassion actually reduces burnout, improves health outcomes, well-being, and resilience among clinicians. You'll find this over and over again in the literature too. Compassion is helpful in the reduction of burnout. So what is it that people in medicine are fatigued by? Because that's the reality of what's going on. In my view, it is the inability to effectively respond to suffering that causes fatigue, not the impulse to help someone, which we hope is innate in many of our clinicians. Now, there are times when experiences are completely tragic and out of our control. I think of Ross's story of the man who was hit by a train. He might have experienced compassion and he simply couldn't help this person. Yes, that can cause distress. That can cause fatigue, right? What I think is most painful, though, is that it is when you can respond, but the lack of resources or system failures or misaligned values of your healthcare organization prevent you from taking action. I think of COVID, not having enough or the right PPE. So you have compassion, but you can't respond safely. Or I think of every day in medicine that I want to respond to this suffering, but insurance denials, bureaucratic red tape, or the emphasis on productivity and RVUs prevents you from staying in a space long enough with a patient who's really suffering. It is the disincentivizing of compassionate action that I think is causing the fatigue, not the compassion itself. Jessica DeDecker says, we've been frustrated in our efforts to fully experience the cycle of compassion. That's what's causing distress. I created this little image to kind of capture what we're talking about here. So you've got someone who witnesses suffering, and innately, often, not always, but often, there is a compassionate response. I want to help this person. So are you able to adequately respond? If the answer is yes, then this leads to compassionate action. This is what connects us to meaning, to purpose, to each other. But if it's no, I can't because I don't have the resources, or it's tragic, or my healthcare organization prevents me from doing so, this is what is leading to what some call empathic distress or moral injury or secondary trauma. And this, I think, is what we mean when we say compassion fatigue. But in my mind, compassion fatigue is a misnomer. We're not talking about the right thing when we're talking about compassion fatigue. We're talking about something else. Distress, moral injury. This is problematic because it implies that compassion is dangerous, and it implies that there is something wrong with a clinician for experiencing the pain and frustration of a broken healthcare system. It points to the clinician and says, you are the problem. You are fatigued by your compassion. Don't look over here at this broken system. You're the problem. And this gets us in a lot of trouble. In particular, it gets us in trouble of perpetuating this idea of I need to maintain professional distance to preserve myself. This idea that I have to detach or compartmentalize to protect myself from feeling too much. I see this in medical students day one of medical school. I'm sure it starts as a pre-med. They'll say things like, I know that I can't connect or get too involved with patients because then I'll have compassion fatigue. I have to protect myself. This is so normalized in medicine. But what the literature shows is that this approach has the opposite effect. Turning away from the suffering of another person can increase your own vicarious suffering, your own feelings of burnout, because you're not responding to that innate call within you that is a compassionate response. Most importantly, I think this prevents the opportunity for post-traumatic growth, which is what we wanted to focus on today. I want to give a shout out to my colleague on the call, Suzanne Danhauer. So I was sharing with Suzanne some of my thoughts on this and how I think suffering leads to development and growth. And she said, Nicole, I think you're talking about post-traumatic growth. And I had never heard of it. And she sent me a beautiful article that she and her colleagues published in Psycho-Oncology that was looking at women with breast cancer and their response to that, many of whom experienced post-traumatic growth. Suzanne, you showing me this has really changed the way I talk about this. So I just want to thank you for that. And anybody who's interested in her article, it's in the works cited of these slides. So what is post-traumatic growth? It's this positive psychological change experienced as a result of struggle with highly challenging life circumstances. Okay, we intuitively know this, that we grow from pain. We can grow. What's important is not everybody grows, but we can grow from these really traumatic experiences in our life can be transformative. What can this look like? The people who write about this talk about an increased ability to relate to or understand others. You could have a gained appreciation for life and more emotional resiliency and strength and spirituality. You can recognize new possibilities for your life, right? I want to talk, before I move to that slide, what does this look like? And if I can share a personal experience that I think maybe captures what we're talking about here. So when I was 19, my mom was diagnosed with late-stage ovarian cancer, and I took care of her for 2.5 years as her primary caregiver before she died. And her death was incredibly traumatic for me. Incredibly. I was enmeshed with her, and when she died, it was very traumatic. I can assure you that I did not grieve after she died. I shut down. However, after she died, I got a master's degree in health communication to understand what went on in that experience. Then I moved to Texas and I got a PhD in medical humanities and wrote a book on vulnerability and grief and suffering. On the surface, it looked like I experienced post-traumatic growth. I was not growing. I was running from myself and running from that pain. The seduction of achievement that made it feel like I had momentum and was growing, but really I was running. It wasn't until a few years later after I moved back to Arizona and my dad was diagnosed with terminal gastric cancer, actually became Ross's patient for a little bit, which is a weird connection between Ross and me. And my dad died a year after his diagnosis. And I think it was then, I was teaching medical students at the time that I really experienced grief, maybe, and I talked to a therapist and I processed through that. it wasn't until then that I think I experienced post-traumatic growth. That I now am more in touch with my grief, and I can feel alongside other people in a way where I'm not shut down. And it was really hard. I think the Japanese art of kintsugi really captures this. Suzanne, you talk about this with post-traumatic growth too, that, this art of taking broken pottery and putting it back together in a really beautiful way. And what's fascinating with kintsugi is they don't try to hide the cracks, but they gild it in gold and highlight the cracks. And for me, for instance, I would never say that I'm glad my parents died. I'm not. Um, but picking up those pieces and rebuilding into something new, yeah, the cracks are still there, the pain, the trauma is still there, but it has created something else, something different, maybe something beautiful in this ability to recognize other people and their suffering. And to me, that's what post-traumatic growth has looked like in my own life. I want to hand this back over to Ross to kind of put back together what we're talking about in healthcare in particular when it comes to post-traumatic growth.
Thanks, Nicole, and thanks for sharing your experiences too, and your personification of the strength of vulnerability. So thank you for your continued example in that for it.
Thank you.
Just segueing to the sort of healthcare situation, as I was just reminded as Nicole was talking about compassion, there have been, functional MRI studies that have shown empathy, activate the pain centers of your brain, but compassion, taking some action to try to alleviate someone's suffering, activates the reward and then the pleasure centers of your brain. And so I'm a firm believer that compassion actually is energizing and not depleting. And I think we have to sort of immerse ourselves in that concept if we're going to sort of overcome this problem of grief. About 5 years ago, I went through a pretty rough period of burnout, and I clearly remember a patient walking down the hallway with a mask on. This is pre-COVID, so in our hospital, anyone with masks on belonged to our lung transplant population. And she grabbed me in the hallway. She said, "Dr. Bremner, it's me. You operated on me 4 years ago, and I'm doing great. And I just wanted to thank you." And I just kind of brushed it off. I said, it's what we do. I was in a depleted state, and unfortunately, I didn't recognize that was a huge opportunity to connect with one of my grateful patients. But, a few years later, my brother was diagnosed with a horrible lymphoma, an anaplastic large cell lymphoma, and he went through a lot of chemotherapy in South Africa, and ultimately he was in remission. And I called his physician, who is a colleague of mine, in fact, in my class at medical school. And I said to him, "David, I just want to thank you from the bottom of my heart, what you've done for my brother and what you've meant to the whole family." And his response was, "Ross, it's what we do." And it just suddenly struck me like lightning that that's exactly what I had said. And I will tell you that his response to me, "It's what we do," left me feeling wanting. He did not accept my gratitude in the full way that I had offered it. And I think we both missed out on an opportunity there. Because I think those periods when we do have patients that want to express our gratitude, I immerse myself into it now. And as we're sort of a prelude to this talk, we were just talking with Janet, and she said she saw a video of me somewhere giving a patient a hug. And it really is what I try to do when a patient says, "Can I thank you? Can I give you a hug?" I immerse myself in that experience, because not only am I receiving something from them, but I'm actually allowing them to express gratitude. Because our experiences with our patients, they deeply affect us. And, when we have adverse experiences and we go through grief, we never process those. And I think there's a huge opportunity for us as coaches to allow our clients to express what they're feeling, because these responses and feelings and reactions matter, and they matter in how we actually carry out our jobs. Just this last week, I was telling Nicole a few days ago that I had an anesthesiologist who was putting a patient of mine to sleep. And when he put the patient down to sleep, the patient, had some hypotension, bradycardia, and he sort of panicked. And really it was not a bad situation in my mind. We just needed a little fluid, maybe, a little bit of a vasopressor, and we got the patient in a more stable position. But it was clear to me that he was suffering what I call medical yips. He'd had some bad experiences, and he had not been able to process this, and he was now concerned. I talked to him afterwards, and I said, talk to me a little bit about, what your anxiety with this case, I think, and he said, look, he's had a couple of cases, and he said, I'd like to just talk to you about a patient that I had a couple of months ago. And he relayed a story that he had, and then he asked me if he thought it was his fault that this patient had died. And this patient had died a few days later. I thought it had nothing to do with the anesthetic, but he had internalized that and been carrying that around. And just me opening the door for him to express himself allowed him to sort of ask me this question, something that was obviously, burning inside him. And I think this happens a lot in healthcare. It happens a lot in the things that we do. And so, I think as coaches, we can allow our patients that safe space to express what they felt during these periods, because they really do matter.
That's right.
So I'm going to ask you now sort of what you think people grieving in healthcare are experiencing. What are people grieving in healthcare? And if you wouldn't mind just typing it in on the chat, and Nicole is going to sort of put these together. But, what are people grieving? Are they grieving just adverse outcomes? Are they grieving sacrifice that they've lost for themselves? Are they grieving the fact that the healthcare system is broken? As Mark Greenwald said, listen, it's been broken for 30 years, nothing's new. But what are we grieving? If you could just type that into the chat.
Oh, we've got loss of an older model of healthcare, more personal and connected, exhaustion, overwhelm, grieving loss of autonomy and control, loss of trust, seeing the need and not being able to meet it, resources, loss of agency. Mary, I think it boils down to grieving a loss of connection, loss of voice, the personal connection to their patients, and having to meet their numbers. Yeah.
Metrics. We're going to meet our metrics.
That's right.
We need some compassion metrics, Nicole.
Yeah, right. Maybe that will solve it. Let's measure the immeasurable. That will solve it. Yeah, thank you all for sharing that. I think you're right. And I see this common thread here, the loss of personal connection, right? Maybe we can boil it down to that. Expectation overload, Janet. Yeah. Being expected to do everything for everyone. Right. That was that kind of perfection that Ross was talking about earlier. Thank you. I asked this question to a group of medical students and physician colleagues and PAs, and this is what they suggested. We made a word cloud. So sure, patient suffering, yeah, they're grieving that. The ones that struck me, right? Loss of my identity, a presumed life, losing relationships, the possibility to love, uncertainty, tiredness, naivety. I lost my naivety, homelessness, my family, adequate staffing. Someone said my 20s. I'm grieving my 20s. Yeah, a lot of sacrifice that is made, familial connection. We hear that with students a lot. They start to feel isolated. Someone's grieving the ability to help. Wow, In some ways, medical students might feel like this was a bait and switch. Come be a doctor, you'll get to help people. We train them, and then their third year, they go into the clinical setting and they go, are we helping anyone? You know, it's really painful for them, for sure. Ross, I'm going to hand this over to you. Oh, almost. Right. Let me go back. I'm sorry, y'all. So the naming of emotions, which you all just did, when you were talking about either what you're grieving in medicine or what you think others are grieving in medicine, is critically important for the coach. And what's really important is refusing that invitation to fix, which we all know. We've all been trained as coaches, to coach the person and not the problem, to not say, how do we fix this? But instead being able to help people name those emotions, to give voice to it, to articulate it. Ross, I'm going to let you introduce what we are going to do for the next 8 to 10 minutes.
Okay, good. So we are actually going to ask everybody to be a little vulnerable, and we'll have a little breakout session, and Janet will pair people up. I want you to just have an honest conversation about, what you have not given yourself permission to grieve. And the listener, as the coach, will name the emotions they hear and reflect them back to the person. I want you each to have a chance to do this, so you can switch your roles and repeat the process. But if Janet, if you could break out the session, and everybody will have a colleague that they can play coach and client as you sort of talk about some of these things that you have not given yourself permission to grieve.
That sounds good. And we have an odd number of folks. I'm going to get I'll go ahead and break everyone out, and then we'll get one of us, Janet or you or me, to jump into the last room, room 8. And then I'll send out a note halfway through that gives you the indication to switch partners. And then we'll meet back here after the breakout room.
Lauren,
Thank
I
you.
noticed someone just left, so you
Oh.
may end up having put something in room 3.
Thank you. Okay.
Mhm.
Thank you.
Yeah.
Let's do.
Debbie Bush, she's in a room by herself. So she could, did you move her to room 3?
Let's see.
I can do that.
Thank you. I'll go ahead and pause.
Oh, wonderful. Welcome back, everyone. Okay, so we're going to take a couple of minutes to just debrief our experience together. And Ross, please jump in throughout this. Someone like to share how that went? Did it feel uncomfortable? Did it feel good to talk about it? How did it feel to have someone name your emotions back to you? We just want to open this up to hear what that experience was like.
We're going to have to call on someone.
Yeah.
I'll talk.
Thank you.
What I have found, and had this lovely conversation with Jonathan, is there's something very powerful about externalizing the internal process. And it shifts the energy around what we're feeling. And it doesn't mean that we're still not feeling a loss or frustration or, fill in the blank. The energy shifts around it and helps to dissipate it when you have a witness. And to me, whenever I've been in therapy, that's been the most powerful aspect of it, is being seen, heard, and valued without being judged.
Janet, that's beautiful. The bearing witness can be healing in a way that we don't really recognize. Jonathan, I know you were with Janet. Anything
Yeah.
you'd like to add to that?
I'll share what I shared with Janet when within 2 minutes of sharing with her where my grief was coming from. She spoke very few words and I got chills on my neck because of how efficient she was in seeing and hearing and feeling what I was sharing. And I said, in a sense, how did you do that? And she said, you just you said it yourself. I was just reflecting it back. So I was struck by the feeling of being deeply seen and seen efficiently, and frankly, by a stranger who is really not a stranger in this context.
Jonathan, did you feel sort of any catharsis by expressing those emotions?
Absolutely, yeah. There's the beginning of tears coming from the lower part of the face towards the eyes, and chills up the spine, and a lightness there. And then Janet began to share part of her story, and there were some similarities there. So which gets back to that quote that, it's when we allow ourselves to be vulnerable, it's when we can acknowledge the grief of others. We need that piece. So Janet clearly was coming from that place.
Wow. I think, Jonathan, what you said of a stranger who's not a stranger to this, the shared experience of suffering, which makes compassion possible. Compassion is co-feeling, and it's not that I'm going to pretend that I can feel the feelings of this other person, but I can tap into my own shared experience of being human, which is constant grief. And this allows me to be with another person in a very real way and the bearing witness. And this is what we can bring to coaching when we are not afraid to name emotions and sit there and reflect it back. People will feel deeply seen. And sometimes that's all they need. And I would say, especially our physician colleagues and our healthcare colleagues who rarely have a place for their grief to go. Maybe it's in the coaching space that it can go. Ross, oh, go ahead.
Karen, go ahead. What I was going to say is, for those of us who are physician coaches and our clients are physicians or other healthcare workers, we have an innate normal response, I think, is to help and to fix. And as Nicole says, that's not our job as coaches. And if there's a little exercise that you can do expressing self-compassion by asking you what you would do if one of your partners had a serious complication and how you would, quote, console them. We never do that to ourselves. But if I think a client is trying to express their grief, they just need to express their grief, and we cannot fix that. They need to, express the feelings the emotions that they're having. So that's the trouble that I have as a coach, is to try to fix the problem of, it wasn't your fault. I mean, this X, Y, and Z. I think the client has to name those for themselves. So.
That's right. That's right. Thank you, Ross. Suzanne, I see your hand up.
Yeah, so it's not a reaction to the exercise, but I know that we're close to out of time. So I wanted to share a thought, is that I love the idea of post-traumatic growth and the idea that we can change from the stressful and sometimes traumatic things that we go through. But I think it's really important to state that to be careful that we shouldn't assume that because someone's been through something big or stressful or traumatic or horrible, that they could or should or will experience post-traumatic growth, like to somehow open it up as a possibility. And for some people that doesn't land well. And so if we try to lead people down this path to post-traumatic growth, I think it's dangerous territory to wander into. And then I'll just add that in response to a number of the comments and talking about kind of parsing out well-being into the individual stuff and the system stuff, I just wrote this thought piece on this, but I really think that it's human connection and figuring out ways to build that connection and community that is one of the biggest keys that we're lacking.
Thank you, Suzanne. Yeah,
Suzanne, would you share that thought piece with the group?
Once it's out.
Thanks. Thank you.
Thank you, Suzanne. We'd love to read that. And I think you're right. So for post-traumatic growth, like when I lost my mom, if someone was like, "You're going to grow from this," I'd be like, stop, that's not where I'm at. And someone might not have or be open to post-traumatic growth until years later. And to not force people to do that is so critically important.
Yeah, it
I,
could sound pretty horrible to say, oh, your life's gonna be so great because
yeah,
you went through X, Y, or Z.
exactly, exactly. Um, And I think that's why as a coach, right? It's led by the coachee. So if there's some emotions, be open to exploring it, but don't say, "Wow, sounds like you went through something terrible. Tell me how you're feeling about that." Let the coachee, the client, guide where that goes. It's critically important. Thank you, Suzanne. I want to be mindful of the time. Anybody who needs to drop off, please do. And thank you for being here. But this is just kind of our final slides about the importance of acknowledging the pain, and I would say, and the beauty of medicine. There are emotions around how amazing it is to be in the healthcare space, and acknowledging that is important. Remember that what happens to people at work affects them outside and vice versa. This is whole person coaching, that it is not separable to the personal and professional self. Do remember that your clients or coaches are not fragile. Sure, we need to not be therapists. We need to not be forcing emotions on people, but you're not causing painful emotions by naming what you're hearing. If they're having these emotions and you name them, you're not creating them for them. Normalize, ask about, and be present for pain because it's there. But remember, we are not therapists. We are not grief counselors. If there's real work that needs to be done with a trained professional who's not a coach, be the conduit. Get them to where they need to go and don't take on that work yourself. I want to return really briefly to the quote we started with about medicine escaping the reality of suffering, and that the coach can be the antidote to this. Viktor Frankl says we give our suffering meaning, by the way that we respond to it. And creating an opportunity for people to respond to their suffering in the coaching space without forcing it on them is exactly where I think we need to go, especially when we're working with people who are in healthcare. Ross, final thought?
No, I think that having an opportunity to talk about this and to think about it has opened up a big can of worms, so to speak. I mean, I think there's a lot more work that I personally need to do in this space, and I think that speaks a lot to the need of having these conversations in medicine. I think that this concept of grief by healthcare workers is something we haven't dealt with very well in the past, and we can do a better job. And I honestly think as coaches, it's a wonderful opportunity to help your healthcare worker clients. And that's all I have to say. Thank you all for being here and for everybody's input. I've learned a lot over the last week and a lot in the last hour, so thank you.
Yeah, and I'll just close this out. Thank you all so much for being part of this discussion. Thank you so much, Nicole and Ross, for the powerful message you're sharing with this group. This is the exact type of conversation we're hoping to bring about through this community of coaches and folks working in the healthcare profession to bring humanity back into this space where it's so needed. So thank you. Thank you. I hope everyone has an awesome weekend. I'm just dropping a link to many of you maybe have heard about our retreat this summer where we hope to have these kind of deep discussions and a space for this kind of reflection. So if you're interested, check that out and let me know. And thank you all so much for being here. Have a great weekend, y'all.
Thank you so much.
Paul
Thank
and
you.
Ross have agreed to generously share the slides if you want them.